I was wondering, Rosie, you're a junior doctor, I'm a young doctor. Is this judgment around recognition and treatment, and Miriam, you're a staff nurse, is it the activity of much more experienced clinicians, or do you feel confident and prepared to have those conversations with your patients? Because often you'll spend maybe more time, or you're more immediately accessible. And I'm wondering if there's kind of a gap in our experience communication curve, which means because you guys are really at the front line, and I don't know, maybe you do, you need to wait for Paul or Claire to come to have a conversation like that with a patient, which means maybe we don't get to it in the way that we ought to.
Yeah, I think when I was first starting out, I found them really intimidating as well. And like I could see with the other juniors, when someone was dying, they didn't want to confront that. It almost seemed like giving up, because you go into medicine like kind of focusing on, prolonging life or delaying death, saving lives, whatever you want to describe it as. But I think now, having worked in palliative care for 2 months now, still a really short amount of time, but I have those conversations every day, and I think the more you have them and the more you realise how important it is for families and patients to be aware of how much they want to be aware of, it just gets easier. And I think it's just something that happens with experience and time.
So experience is beneficial, but just confidence is kind of what you're describing as well, and working in the team and with colleagues. I mean, clearly that's very helpful.
Yeah, and also kind of understanding, again, like the keyword, like holistic, like the holistic approach, that our role isn't just to prolong life at all costs, it's really to see what is best for the patient and what the patient wants.
And did you discuss that? Was that part of your, because you said quite rightly and completely understandably that most clinicians enter medicine, or nursing indeed, with the sense of healing and recovery. Did you think much about the kind of other, what might happen? Was it discussed at medical school? Was there much time spent reflecting on
Not really, actually.
Death and caring for
We had maybe 2 days in palliative care.
2 days out of 5 years.
Out of 6 years, yeah.
Wow. Not a lot then. I mean, I know there's a lot to learn.
And no, there wasn't much focus.
So it's so
on
fascinating.
dying.
I mean, it's kind of a reflection of what we were saying earlier about this sort of societal approach to it. I mean, if you think about your patients, which is everybody, the only thing you're going to meet with absolute certainty for every single one of your patients is they're going to be born or they're going to die.
Yeah.
And yet you're not having a lot of time as part of your preparation.
Well, yeah, I was saying before starting work, I hadn't seen a dead body, and then suddenly now it's a daily thing in palliative care and on many other wards.
I think that's common actually. I certainly had never seen a dead body till I started my training. Dana, your experience, you've been working overseas as well. Have you got? Is it different or
the process isn't different, but I think in the last hospital, I've recently come back from Australia, so one of the we did a quality audit on sort of death audits, what do we do and what we do well. So we had an inspection team come in, and because we didn't have a palliative care suite, but how we managed the process on the wards, people were very engaged. It was a topic, because where we work is quite an ageing population, so it was actually dealt with and managed, and I hadn't really seen that in any of my experience in the acute sector before, but how it sort of integrated, people knew about that, and because it was quite community, like the community would know who was in the hospital, so it had a really different feel to it. Going back in my experience, when I first started, we had the old Nightingale wards, and we didn't do really long shifts, so you do standard sort of short shifts, and you really got to know your patients, and you could walk onto the ward and I think that person's transitioning on their way, to dying, and there's something about the patient when you know them long enough that you see it, feel it, that it's coming, and and it's quite interesting how other people don't. And I think it does confront your own mortality when we work around that. I think going back to a point you made earlier, I think for some people there's a fear of getting it wrong or saying something, and I think a lot of people recognise and want to say something, but that fear of getting it wrong and upsetting everybody, and then if you're a bit junior, you know, it would be who gave you that authority, and there's that fear about having that authority within your role, even though you feel it, so clinicians feel it, and I think we need to, you know, look at that. How do we empower people? How do we, you know, this is what I feel, and we're sometimes black and white ways of evidence, but actually we can feel it, we all know it.
It's so interesting. What, Miriam,
Like,
what's your experience as
Well,
a
it's like
staff
whether we
nurse?
do we all need permission, regardless of which role, even healthcare assistants, they're spending the majority of the time actually with patients and are most available to have a conversation. But are we comfortable talking about our own death? Have I made a plan myself of how I want to die? So I often think about it. If I want to be able to be comfortable having a conversation with someone else about their death or with a family member, have actually gone this through myself, regardless of how old I am, because we do. People are faced with death at different ages. Yes, we talk about, you know, the 90-year-olds but it can be any age that you're dealing with death. I certainly, like with in my experience, I've seen death in different countries and seen how different people cope with that. And coming from New Zealand, seen how the indigenous people, the Maori, they like to celebrate their relative by sleeping next to the dead body, and that's how they grieve. So I learned from that because I found they're comfortable with that dead person. Whereas
you can't imagine that happening here, really.
No.
Or it would seem very odd. I think people might think that were odd.
So it's kind of like, for me, that comes back to how am I working on myself to better improve how I approach other people with my communication. Am I comfortable with these words, with these elephant words that no one wants to speak?
I think you raise a really good point. I mean, I'm sitting here thinking, have I? No, I haven't. But I tell you what I have done, and I think this speaks to my fear. So my fear is what happens to me afterwards. So currently, if you were to ask my husband what were to happen to me if something awful were to happen, he would say, well, completely unpractically, she said just prop her up in the garden by a tree. Which, you know, is completely not going to be able to be delivered, is it? I suspect where we live that might prove a bit of a problem, because I've got this terrible anxiety about all of the options. So name them. So being buried, I can have a great concern about the creepy crawlies. So that's off. Being cremated, that one, I saw a James Bond film once where the man was in the have you all seen that one where he's inside the coffin and trying to get out? So that's off. And I'm starting to run out of options now. Now I was in the Navy, so I could be buried at sea, but that would be too cold because that's what my husband would like. But I haven't ever discussed or talked to anybody in my family about the process or where I'd like to be, or it's so challenging.
Can I say something?
Yes, Marjorie.
I've left my brain and spinal cord to the brain bank in London.
Yes.
My husband died of dementia after 15 years, and he left his. He was in a research programme up at Charing Cross at the time, until he could no longer do it. And so that I knew exactly what would happen. I had power of attorney, was registered with the Court of Protection. Everything was planned, and it was brilliant, I have to say. It was, and I knew exactly what he wanted. We had discussed it when he was first diagnosed. He was about 16. He was able to, you know, he sort of had capacity then. No, it wasn't. And so the minute he died, he was in a nursing home. It was through a Christmas period, and I had to make sure that we had a syringe driver up for him at the end. I did not want him thrashing about. I wanted him at peace. And so the GP gave us a range of drugs on the pink chart so that the nurses could increase it if it was necessary, legally and so on. So when he died, I'd been to the undertaker previously. They said, yeah, we'll collect his body and we'll whip him over to Guildford. They removed the tissue that they wanted and sent him back. And I really wanted to make sure it was him I got back. So I did ask, I wanted to see him in the coffin. My daughter and I went. So then when he had died, they were still looking for people to research, sort of with so-called normal brains at the moment. So they were looking for volunteers. So I said, I'll do it. Yeah. So now I'm checked every 12 months, and someone does a test, memory test, and come out to see me and check. Now they're looking at vascular dementia in a particular way. And so my daughter is very well aware of exactly what's to happen to me when I die. I've paid for my funeral, I've planned everything, it's all written on paper, I've been through it with her, and it is not a problem. I talk about it to my grown-up grandchildren who are absolutely horrified. They can't imagine life without me, their life without me in it.
Of course not.
But I said, well, it's going to happen.
Yeah. And what do you think liberated you to be able to have conversations like that?
My
with
district
family?
nursing career.
Yeah.
It was being with families. District nursing is a brilliant job, I have to say. You have that moment of getting to know your patient and family.
Yes.
They trust you. You give them, all the support you can. And we had the services then. There was many of us, and we could offer that with a GP, palliative services we could rely on if we needed assistance. And I think maybe it just grew on me. I was so admired people who could reach the end of their lives with and able to discuss it. And it was the home environment that enabled them to do that. Yeah. And the more they planned, and you could encourage people to talk because you were in this atmosphere. Yes. In their own homes with a log fire burning perhaps, and you could talk about that.
Well, they're in control there, aren't they?
Absolutely in control. In the hospital you really hand yourself over, and many of the elderly were in awe of their doctors. They didn't question what the doctor said. They put them on a pedestal, and if the doctor said it's like this, so be it. Many of the elderly handed it over, didn't they? Didn't really want to face up to it, where now everybody the youngsters will question things much more. Yes. And internet's out there too, unfortunately.
I think it goes back to Paul's point where, that older generation still, the doctor's not, the doctor's far too busy, so I shall speak to the nurse about it. And we're still seeing that as nurses. I didn't want to ask the doctor because they're very busy. So to ask the other questions, and quite often what the answer to those the nurses might not have, but do have that little bit more time to have that level of conversation.
Time is so precious and difficult, isn't it? Yeah. And what you're describing, Margie, that the hospital is just totally the other extreme.
Absolutely.
Isn't it?
Yeah.
The patient arrives in a crisis. Yes. Frequently we don't have any relationship with that patient, or occasionally we might know them from our outpatient or something. Sure. And you're trying to have a really quite difficult conversation.
It's very tough.
And it's not just with the patient, because often the patient, if you make the time to talk to the patient, often they'll have quite clear views, but it's much more difficult then to talk to the relatives. Because the relatives are very frequently on a completely different page.
Yes. And they brought them here for us to do something. Otherwise they would have still be at home.
And often life continues, doesn't it? And it's then, and what I find often very difficult is getting everything together in the one place. So getting the patient and the relatives and everything,
just the logistics,
and have that conversation, and that's often very difficult.